Bismillahirrahmanirrahim. In this lecture, we will discuss the tumors of the hypopharynx. Tumors of the hypopharynx may be classified into benign and malignant tumors. The benign tumors are uncommon. They are papilloma, adenoma, lipoma, fibroma, leiomyoma. Whereas malignant tumors, they are more common in hypopharynx as compared to benign tumors. These are squamous cell carcinoma with various grades of differentiation. Commonest is about 90% is the squamous cell carcinoma. Lymphoepithelioma, adenocarcinoma, and lymphomas, which may be Hodgkin's lymphoma or non-Hodgkin's lymphoma. In this figure, you can see in the upper figure, there is tumor involving the left piriform fossa, and in the lower figure, you can see a metastatic lymph node close to the angle of the jaw in the neck. Now we will discuss the carcinoma of the hypopharynx. In this figure, you can see the site of hypopharynx, that is below the level of the hyoid bone up to the lower border of the cricoid cartilage is the hypopharynx. Subsites of the hypopharynx and incidence of cancer. These subsites in decreasing order of frequency are: number one is the piriform fossa or piriform sinus. This is the commonest subsite to have carcinoma to develop, round about 60%. Second is the post-cricoid region. The incidence is about 30%. The third subsite is the posterior pharyngeal wall. This is the least common site, and the incidence of cancer development in this region subsite is about 10%. Epidemiology. Hypopharyngeal cancer is quite common in our country, but rare in developed countries. About 2,500 cases are diagnosed each year in the United States of America. This cancer is difficult to be diagnosed in its earliest stages and has one of the highest mortality rates of any head and neck cancer. Any age may be affected, but it is more likely to affect people over 50 years of age. It is more common in men than in women, except post-cricoid cancer, which is more common in women. There are different types of hypopharyngeal cancers, but the most common is the squamous cell carcinoma, which is around about 98%. Etiology. Exact etiology is not known, but there are certain risk factors responsible for this cancer. These are smoking, chewing of tobacco, heavy alcohol use, a diet low in vegetables and fruits, chewing of betel quid, which is a stimulant commonly used in certain parts of Asia, Plummer-Vinson syndrome, especially in post-cricoid carcinoma in females. Grossly, the malignant tumor in the hypopharynx may be exophytic, it may be ulcerative, or it may be infiltrative. Histologically, the cancer of the hypopharynx may be squamous cell carcinoma, which is the commonest one, around about in 98% of the patients. It may be well differentiated, it may be moderately differentiated, or it may be poorly differentiated. Apart from squamous cell carcinoma, the other types of malignant tumors may be lymphoepithelioma, adenocarcinoma, lymphoma. Spread. The malignant tumor in the hypopharynx, from its primary site of origin, it may spread by three ways. Number one, local spread to adjacent tissues through the tissue continuity. Second, lymphatic spread through the lymphatics to the regional lymph nodes. And third is the blood-borne spread through the capillaries and veins to the distant organs of the body, for example, lungs, liver, bones, and brain. Clinical features of hypopharyngeal cancer. Clinical features depend upon site of the malignant tumor, stage of the tumor. Different possible clinical features may be a sore throat that persists. The patient may have dysphagia, rhinophagia, or unexplained weight loss. Change in the quality of voice, hot potato voice, for example, ear pain, bleeding from the throat or mouth, bad smell from the throat, a lump in the throat, or sometimes the patient may have a lump in the neck due to lymph node metastasis, especially in a case of if the tumor is developing in the piriform fossa due to rich lymphatics, the patient may have a lump in the neck due to lymph node metastasis. Investigations. Apart from routine investigations, the specific investigations are blood complete examination with peripheral film, especially important in females who are expected to have post-cricoid carcinoma. CT scan of the head and neck from base of the skull to the root of the nose to the root of the neck to delineate the extent of the tumor and to know the lymph node metastasis. MRI and PET scan and direct laryngoscopy and biopsy, which is confirmatory for these tumors. Diagnosis. Diagnosis is made from history regarding clinical features and risk factors, physical examination of the patient, including inspection, indirect laryngoscopic examination, palpation of the neck for lymph nodes, and lastly, investigations as I already mentioned. Treatment. Treatment of hypopharyngeal cancer depends upon different factors. For example, age of the patient, fitness of the patient, site of the tumor, extent of the tumor, lymph node metastasis present or not, type of histology of the tumor, facilities available at the center, experience of the surgeon, etc. Treatment policy. First, piriform fossa sinus tumor. If the growth is early, then radiotherapy is offered to the patient. And if the growth is limited to the piriform fossa and it has not extended to the post-cricoid region, then total laryngectomy plus partial pharyngectomy followed by primary repair of the remaining pharynx. Neck dissection. As piriform fossa has a rich lymphatic network and about 70% of the patients have cervical lymph node metastasis when first seen. Therefore, elective or prophylactic block dissection of the neck lymph nodes is also recommended. If the growth involving the piriform fossa and extending to the post-cricoid region, then the patient will be offered total pharyngolaryngectomy and partial esophagectomy, plus block dissection of the neck. Repair of the defect with myocutaneous flap, for example, pectoralis major myocutaneous flap or stomach pull, and planned post-operative radiotherapy is also given routinely to all these patients. Carcinoma of the post-cricoid region. Generally speaking, prognosis is very poor with both radiotherapy and surgery. If the cancer is at an early stage, then the patient should be offered radiotherapy. If radiotherapy fails or the tumor is at advanced stage, then total laryngopharyngectomy and partial esophagectomy followed by stomach pull-up or colon transposition to reconstruct the pharyngoesophageal segment. This is a figure showing in the upper part tumor involving the left piriform fossa, and in the lower figure you can see the metastatic lymph node in the neck. This is the CT scan showing the hypopharyngeal tumor. Again, axial view of the CT scan showing hypopharyngeal tumor. Thank you so much.